on that note, so statin is like his regular Wednesday CME, and Bempedoic acid is something which is beyond that, which is more exciting. So if we see there is no denial that the lowering the cholesterol would lower the cardiovascular risk and outcome, and cardiovascular disease has become a #1 killer globally, and we know it very well. And if you see the leading cause of mortality globally, it is the cardiovascular disease. And when we say cardiovascular disease, all the vascularity, right from the cardiac vasculature to brain, and also that is why the overall disease burden is something. So 1 out of 3 deaths worldwide are due to cardiovascular disease process. You can imagine the magnitude of the problem, and it is the leading cause of mortality. So as I said initially, that it is both the combination of the ischemic heart disease, which is the #1 killer, and the stroke. So all the vascularity is the leading cause, and ischemic heart disease is the 16% of the world's total death. So that is what we say, that the final common pathway of the death is the cardiovascular cause. So we need to conquer this, and with the improved pharmacological management, definitely the longevity has increased, the quality of life has increased. And in the same vein, we say that 11% of world's total death, and as the age advances, stroke also takes a toll. And definitely the LDL cholesterol and the high lipids are the #1 cause for that also. So 11% of world's total death is because of the stroke. So global burden of, if you look at the disease data, initially because the pickup rate was also low and the quality, people were more, at the risk factors were lesser. It was ranked as #4. Now, after some time it became, cardiovascular disease became as a #2 killer disease. And if you look at the India in particular, they definitely, you see age, standardized cardiovascular death rate of 272 per 100,000 population in India, whereas the global average is significantly lesser, 235 per 100,000. So definitely in India it is a much bigger menace. So ischemic heart disease and stroke are the predominant cause, and these are the manifestation of atherosclerosis, which will cause this to our life. So more than 80% of cardiovascular death happens because of this predominant cause. So how have the leading cause of death and disability combined changed from 1990 to 2016? So in this era, as a country, we have paid a huge price as far as the progress and prosperity is concerned. In our country, the data suggested before 1990 that cardiovascular death was ranked #6, but if you see today, it is #1. So if you see the treatment options, so definitely the target is the LDL, or what we call bad cholesterol, and we need to bring it down. We had the option, as Dr. Chauhan said, with the statins, then we had the option with the ezetimibe, and also we had the options of the fibrates and the Pcsk9. So fibrates were, so apart from statin, and off late we had some data that ezetimibe will also decrease the cardiovascular risk and cholesterol, of course. But fibrate would decrease the triglyceride, but it is not really translating into the decrease in mortality. So statins, we know that rosuvastatin and atorvastatin is the pillar of the management of dyslipidemia. Fibrates, phenofibrate has been being used, but obviously it increases the side effect, and it also does not in, if you standalone fibrate, it might decrease the triglyceride, but it does not translate into mortality benefits also. And then we have got off-late data has shown that ezetimibe is a good add-on for statins. Of those who cannot tolerate it, we can give them ezetimibe. And then Pcsk9 inhibitor is a very, very potent and effective molecule, and we have seen that if you add it on statin therapy, it decreases the cardiovascular mortality significantly. But it has got a huge price to pay because it's a costly thing, injectable, so that makes it not a user-friendly thing. Statin-wise, we know for ages now that we have two most potent statin which is available right now in our country. We don't have much availability because it's not being used regularly. Atorvastatin and rosuvastatin is a pillar of dyslipidemia management. If you look at the statin management, as Dr. Chauhan has also said, this is the HMG-CoA reductase where the statin would work and would decrease the total LDL. So benefit of initiating the statin in early is that it will lower the LDL cholesterol, and also it has got a lot of pleiotropic effects. And endothelial dysfunction will be restored and can be decreased. The inflammatory properties of the endothelium would go down. Episodes of ischemia would be reduced. Vulnerable plaque gets stabilized. So unstable plaques get stabilized, and also the cardiac event would be reduced. So absolute LDL reduction is something which is really, so if you see the maximum LDL reduction that was seen with the high dose of rosuvastatin followed by atorvastatin. So this is what we mean by high intensity statin therapy, where 40 mg rosuvastatin or 80 mg of atorvastatin is to be given in our patients. So if you see, there are two ways we go about. One is the primary prevention and the secondary prevention. Means that those who did not have events but have risk factors, we go for primary prevention in dyslipidemic patients. And the trials after trial have shown that both the strategies in primary and secondary prevention, this is something which is good, but residual risk is still there. There are a lot of patients where the LDL and the triglyceride and everything would be well in control, but the patients would have significant adverse outcomes. So if you see that is it feasible to increase the statin dose in all situations, the answer is no, because Dr. Chauhan also said in the beginning that a lot of patients may not tolerate statin, they would have myopathy, the muscle pain and all. And the certain patients who have liver enzyme issues and also they would not really tolerate it. So can we get rid of residual risk with maximum dose of statin? TNT study did show that if you use 80 mg of atorvastatin versus 10 mg, then definitely the cardiovascular disease and the event rates go down significantly. But definitely that's not, still you have residual risk which will be there, and we need to target that. Statin-associated muscle symptoms, that is SAMS, which is there, is something which is, today also I had two patients who came and said that, I had been told by my friend that you do away with statin, take something else because it causes muscle discomfort and pain. So I said, no, unless you have it, it's not that it's 100% the side effects will be there. So tolerability of statins, and especially so much of negative about this is written that a lot of patients would have, even if he's not taking tablet, even if in the name statin, if they are taking a placebo tablet, they might have some muscle aches and pain. So discontinuation, myalgia, elevated CKL elevation and transaminase elevations, these are the issues, and you will not be in a position to continue it for obvious reasons. In those situations, you might have to discontinue, and there is enough data to suggest that if you discontinue atorvastatin or rosuvastatin, event rates go significantly high. So statins as a class has got higher odds of diabetes and transaminase elevation, we all know. Then some patients would come and say that my liver enzyme has gone a little up, and we say that it means nothing, it means that you are compliant to your medication. So you need to see that transaminases have gone up or not, but it's not that 100% of the patients will have higher transaminases. And obviously the diabetes rate also, especially with rosuvastatin, goes slightly higher, but the protection which it gives outweighs the risk of getting diabetes, or mostly the pre-diabetics would go into diabetic range. So high intensity statin therapy is a class 1A recommendation as far as the ACC, AHA and ESC guidelines are concerned, and you can clearly see the lower the better the target has come, and now we don't even go for LDL cholesterol target in secondary prevention to less than 70, now we target it to be less than 50 or 50% of the baseline LDL level. So if you see the lead study sub-analysis, and that clearly shows that the atherosclerotic cardiovascular disease, if the risk is high, then we need to target high intensity statin, and if the risk is intermediate, then intermediate dose, and then the low dose as a primary prevention in these cases. But suboptimal adherence to guideline recommendation dose of statin for the management of diabetic dyslipidemia leads to higher event rates. So, and that is what the lead study sub-analysis showed, that if you are just taking statins for the sake of taking it and don't achieve the targets, then definitely the evil rates will be significantly higher. The suboptimal LDL response to statin is a barrier, and some of the physicians also have a barrier, and the patient also. So both ends the barrier is there, and we need to overcome that. So in real life, definitely there are patients who may not tolerate higher dose. Then we need to add on, so and that is what the residual risk and residual gap was there, where we did not have anything other than fenofibrate and all to offer to that. So that led to, and we were searching for something, and then the Bempedoic acid has come. So this is showing that the gap between the recommendation and clinical practice is significantly high. So combination therapy has got a higher chance of attaining the LDL cholesterol goals versus higher statin dose. So till now, as Dr. Chauhan was also saying, we were using statins, high dose statins, then ezetimibe, and then also Pcsk9 inhibitor, those who could afford and manage it. But the suboptimal LDL cholesterol response to statin therapy and cardiovascular risk is well known. So even if there are certain patients where you give the maximum dose and still they could not achieve the target levels of LDL cholesterol, so they have got definitely higher risk of this. So there are different approaches recommended by American Heart Association and the ESC guidelines to achieve the common LDL, and obviously we need to go step by step. So the patients who have got multiple risk factors, like those who are diabetics, have got higher atherosclerotic cardiovascular risk, those who have got multiple risk factors like hypertension, smoker, family history, and familial dyslipidemia, then we need to go beyond the maximum dose of aggressive intensity statin. We need to add ezetimibe, we need to add Pcsk9 inhibitors. But still we felt that the gap is still there because a lot of patients would not really achieve the target, and we need to do something more about this. So you can see that the statistics on statin therapy inadequacy is clearly highlighted in this slide, that 22% of the statin users are affected by the muscle symptoms, which we call SAMs, and significantly higher level of CPK. So there are many times where we need to decrease the dose or even completely withdraw the statins. 15% of patients suffering from statin-induced side effects discontinue their therapy. 16% achieve LDL cholesterol attainment for less than 70 milligram per deciliter, and 29% patients discontinued statin therapy within the first year of initiation of the therapy. So I think these are the issues where we need to be really mindful of that. That this clearly shows that there is some problem with this statin therapy. So current treatment option and unmet need, as we say, that the discontinuation of statin therapy, SAM is there, then we add ezetimibe, but that also has lots of side effects like abdominal pain, diarrhea, and intolerance. Pcsk9 inhibitor, we know that it's an injectable drug, so higher cost of therapy is there. So what next? We are still searching, and then these limitations in the therapy in terms of effectiveness as well as tolerability, adherence, and access. The unmet need for an additional oral and well-tolerated option for lipid lowering is there. So here is the answer now. Very recently we have got access to this molecule, Bempedoic acid, which is something which would be really a game changer as far as the statin, LDL cholesterol or dyslipidemia management is concerned. If you look at the indications, definitely it is indicated in patient who has got primary hypercholesterolemia, and those who are on, had mixed dyslipidemia also. So obviously all the, statin has got such a powerful data that whatever the next therapy has come, we need to use the, in combination with statin, whether it is ezetimibe, Bempedoic acid, or even Pcsk9 inhibitor, despite being so robust, because you can't really leave statin unless the patient is intolerant. So the mechanism of action, as you clearly know, that it is also using the same pathway where the liver enzymes are there. So this is the place where Bempedoic acid would work. That is, in the liver enzyme, we know that SMG-CoA reductase is something where the statins would work and prevent, decrease the secretion of cholesterol. But one step before, where the the citrate to acetyl CoA is there. So this pathway is blocked by the bempedoic acid. So bempedoic acid also upregulates the hepatic LDL receptor similar to statin, which is ultimately responsible for removing the LDL particles from circulation and does the trick. The bempedoic acid is protective mechanism against the myotoxicity, and it has been also highlighted by Dr. Chauhan in the beginning that what it does is that ACSL1 is expressed primarily in the liver and not in the skeletal muscle, and this is where the activity of bempedoic acid is there, which is an active form. So bempedoic acid neither have an effect on cholesterol synthesis in muscle cells nor induce the muscle-related side effects, and that is why those patients who do not tolerate the statin and have got more myalgia, muscle pain, especially CPK goes high, there we can really use this and would help in those set of patients. So if you see the product profile, it is an adenosine triphosphate citrate lyase inhibitor and has got strength in 180 milligram once a day uses, so that's very user friendly. And we need to do once daily, and there is no food interaction significant, so we can give with food or without food also, and the storage can be kept at the room temperature. So look at this data, so it's a relatively newer molecule, and we need to look into the data that clear trials, multiple of them did so that more than 17,000 patients, so Clear Harmony was having more than 2,200 patients, Clear Wisdom had nearly 800 patients, Clear Serenity has nearly 350 patients, and Clear Tranquility had nearly 275 patients, and outcome trials which were 14,000 plus patients. So the evidence in Clear Harmony trial showed regarding the bempedoic acid, and it was data was for 52 weeks, and objective was to assess the safety, side effect profile, and efficacy of bempedoic acid therapy when it was added to use of maximally tolerated statin for 1 year. Then what you see, the incidence of overall serious adverse event did not differ substantially between the two groups, so it is very well tolerated. Muscular disorders and all is also significantly lower. So definitely this is a molecule to look forward to. And if you look at the scientific evidence one, the treatment with bempedoic acid resulted in greater lowering of LDL cholesterol level than was observed in placebo group. So 18% LDL reduction over 12 weeks is very, very impressive reduction in LDL. So again, it makes that it is much more stronger than ezetimibe, which is still now was standard of care as an add-on therapy to statin. And it also showed that in this 52-week trial, bempedoic acid added to maximally tolerated statin therapy did not lead to higher incidence of overall adverse event than placebo and led to significantly lower LDL cholesterol. So basically, discontinuation rate is significantly lower and the tolerability of this drug is significantly high. Also, you could see that when you compare with placebo, epiprotein B and HSCRP were significantly lower. So it means that on those targets also, like Pcsk9 inhibitor, it works and decreases the inflammation. So you can, if the patient has got significant raised HSCRP, which is a predictor of acute coronary syndrome, then in this situation we should be using bempedoic acid to decrease the CRP level further and decrease the risk of acute coronary syndrome. So every doubling of statin dose would cause on an average only 6% additional reduction in LDL cholesterol concentration, which is, we call it rule of 6. So we need to add other molecules, then you will get significant other decrease in the cholesterol level. So although statin and bempedoic acid work through the same cholesterol synthesis pathway in different levels, the additional reduction in LDL cholesterol level, which bempedoic acid therapy, when it was added to moderate intensity statin therapy, greater than 6% reduction. So it broke the rule of 6 and therefore did more synergistic effect. So if you look at the Clear Wisdom trial data, and again this was 52 weeks trial to assess the efficacy of bempedoic acid versus placebo in patients at high cardiovascular risk receiving maximally tolerated lipid lowering therapy. So here also the reduction in LDL levels were observed at week 12 and were maintained throughout 52 weeks in bempedoic acid arm. And you can see here that there was 17% LDL reduction in week 12. So it means that the reduction is there, and that same kind of reduced level continue, and that was for 52 weeks. So meaning thereby that it is really efficacious and allows the level to be maintained on the lower side. Again, if you see the secondary endpoint, there was significant reduction in 12 weeks versus placebo were observed for the levels of non-HDL cholesterol, and we know that non-HDL cholesterol are the biggest culprit for residual risk of cardiovascular events. So FOB and HSCRP, which is a residual risk cause, that also goes down. So like you do with the Pcsk9 inhibitor, that is costlier option with the bempedoic acid, these two markers will also go down, and eventually they will decrease the risk factor. So among patients with those who have a high risk of cardiovascular disease receiving maximally tolerated statin, the addition of bempedoic acid compared with placebo resulted in significant lowering of LDL cholesterol level over 12 weeks. And mind you that the HSCRP and the FOB would also go down, and by virtue of that it will decrease the risk further. So clear SERENITY trial, again, that was to look at the safety and efficacy and tolerability of bempedoic acid versus placebo in patients who are statin intolerant. So what happens in patients where the patient is, you have to take off the statins, and there also the patients had tolerated it well, and there was significant reduction in LDL cholesterol. Secondary lipids and biomarkers were observed at 12 weeks. So again, at 12 weeks, there was significant, so meaning thereby that standalone, even if you are not able to give it with statin, there will be significant reduction in overall the LDL cholesterol level. And also the significant reduction at 24 weeks with bempedoic acid compared to placebo. There, the LDL cholesterol, non-HDL cholesterol, FOB and HSCRP were maintained up to 52 weeks. So it's not that there is an early drop and then there will be research. It's not like that. There will be, the maintenance of the same if the patient continues the medication. So it's a good news that your HSCRP goes down, your LDL cholesterol goes down, apolipoprotein B goes down, total cholesterol, and non-HDL cholesterol, which is again a cause for residual risk, is also going down. So the bempedoic acid offers a safe and effective oral therapeutic option for lipid lowering in patients who cannot tolerate the statin. Again, the clear tranquility data, that was the efficacy, that how much you can give. So to evaluate the efficacy and safety of bempedoic acid 180 mg daily when added to background therapy with ezetimibe 10 mg, in that significant reduction in LDL cholesterol, secondary lipids and biomarkers were observed at 12 weeks, and that was also significantly reduced. So bempedoic acid may provide an oral therapeutic option complementary to ezetimibe in statin intolerant patients who require additional LDL lowering. So a lot of patients where we had no other answer, but so there are many patients where even 5 mg of statins would make them symptomatic. They severe muscle pain, weakness, and all. So in those situations, we have got some options, and there are many patients where they had familial hyperuricemia, they needed bypass at the age of 35, 40, and they could not tolerate even 5 mg of statin. So in those cases, we did not have anything to offer except Pcsk9 inhibitor. But now this is a molecule which will fill that gap. Again, there is clear scientific evidence, 5 clear outcome trial data, which is an ongoing trial on bempedoic acid. And that outcome will determine whether bempedoic acid 180 mg daily reduces the incidence of adverse cardiovascular event in high vascular risk patients with documented statin intolerance and elevated LDL levels. So definitely it decreases the LDL, but does it increase the event rate? So there are, as I said to begin with, that phenofibrate, even if decrease the cholesterol and triglyceride, does not translate into decreased event. But does this molecule stand alone without the help of statin would decrease the cardiovascular event rate? The preliminary data definitely shows that it would, but we have to standalone therapy, we have to wait further. So efficacy and safety of this molecule alone or combining with lipid lowering therapies in hypercholesterolemia patient, a meta-analysis of randomized controlled trial was there nearly 5,000 patients in 13 randomized trials were included, and next scores were given, and that showed that the pooled data showed that both bempedoic acid monotherapy and combining with statin or ezetimibe were all significantly reduced the LDL level. So definitely there is no doubt that this is going to decrease the LDL level, but when compared with statin and ezetimibe alone, the combination resulted in an additional LDL cholesterol level reduction. So definitely this is an add-on benefit. It will decrease the LDL cholesterol, but everything, if it is a medicine, it will have a side effect. So don't think that it is free of any side effects. So it is having the effect of, it can cause anemia, it can cause gout or hyperuricemia, which is the commoner side effect. Increased aspartame, so liver enzymes would be high. Pain in extremities would be there, though it is not significant muscle pain, but extremity pain has been shown. And the blood creatinine, urea, and decrease in GFR are very uncommon side effects. Nonetheless, we need to know, because now the patient will come to you Googling these side effects. So if you look at the contraindications, obviously in pregnancy, breastfeeding individuals we can't give, and those who are hypersensitive to this ingredient we cannot give. And concomitant use with more than 40 milligrams in statin has also been shown to be adversely affecting, so that's again a contraindication. So if you see this, that special warning and precautions to be used, potential risk of myopathy with concomitant use of statins. The bempedoic acid increases the plasma concentration of statin. So if somebody is having statin-induced myopathy, come down the dose of statin, because when you add bempedoic acid, the statin's level will go up and cause more myopathy, and you will think that you have added on the molecule, and it should not happen. So that's not true. Monitoring the patients for the adverse effect, and the reaction that are associated with the use of high-dose statin like myopathy. So we need to be mindful. We can always, continue to do cardiac, muscular enzymes like CPK and all, and lower maximum dose of same statin or alternative statins, not discontinuous from bempedoic acid, and initiation of alternative lipid lowering therapy should be considered under close monitoring of lipid levels and adverse reactions. If the myopathy is confirmed by raised CPK more than 10 times of the normal values, this bempedoic acid and any statin that the patient is taking concomitantly should immediately be discontinued. So that's one indication when it should be. So it began with that those patients who are statin intolerant, we should be giving bempedoic acid, but it's not true that it will not cause myopathy. So those incidence is lower. So we should be withdrawing this molecule, give a holiday period, and then restart with bempedoic acid alone. So obviously there are certain contraindications, we have already discussed about that, but you don't really need to do a dose adjustment. So if one size fits all as far as this molecule is concerned, so you have to give 180 milligram in everyone, and so if you see the Lipid Association of India also had given an expert consensus statement in 2020, and if you see the place of different statins, obviously we can begin with high-dose, high-intensity statin. We can add instrumentamide, Pcsk9 inhibitor can be added, and then after that the scene of bempedoic acid came. So to conclude, friends, I would say that the bempedoic acid has a unique and novel mechanism of action, and the target is underlying pathophysiology involving the LDL particles from circulation, which results in lowering the LDL cholesterol level. And it's a prodrug, and it's an enzymatic activation occurs in liver through an enzyme called ACSPL1, and this enzyme is not present in adipose tissue or muscle, which may explain the muscle complaints with bempedoic acid. It's a novel oral and non-statin drug approved in 20 years, and that is why after a long wait this new molecule has come. An additional bempedoic acid therapy demonstrated up to 28% reduction in LDL with once a day doses. Thus, it is a promising drug for patients requiring additional lipid lowering, and it's a promising drug for patients who cannot tolerate statins. So we have something which we can offer, and it fills the gap between the statins, ezetimibe, and Pcsk9 inhibitor, because it's significantly lighter on the pocket of the patient as well. And being an oral drug, it would have a definite advantage over Pcsk9 inhibitor, not only cheap cost-wise, but also the ease of use also. And it has been well tolerated in clinical trials with majority of adverse events are mild or moderate, and so that is why it is a good therapeutic options in these patients. So, it has got a unique mechanism of action, proven efficacy, safety, and it's a valuable armamentarium in the dyslipidemic patient. So, thank you very much for your time.
Thank you very much, sir, for a wonderful deliberation of Bempedoic acid, a new molecule to achieve LDL. Sir, we only have one mic.
No,
so,
right, you can come there.
No, we will have to give this mic to few people, so we'll stand here. So people can hear, sir.
Dr. Arya is coming in between me.
No, no.
Why don't you come there, sir?
या आप इसको वहाँ पे रख देंगे माइक को. ये माइक को वहाँ पे रख दीजिए. वहाँ पे रख दीजिए. फिर ठीक है. So friends, I think first of all, let's give a big hand to Dr. Viveka for this wonderful deliberation on Bempedoic acid. I think you would have understood the basics about this. I would like to reiterate those points just for the benefit of those who may not have understood it, although it was abject silence during the talk, and I am grateful to you for that. Bempedoic acid, you have to understand, is an addition to statins. So please do not go away with the impression that this is a new anti-cholesterol medication and can be used in place of statins. Where do you use it in place of statins? Only in people who are truly statin intolerant, or you call them truly statin hypersensitive. So in those people, you will have to use Bempedoic acid to achieve the targets. And we also understood from Sir's talk that there is a population and subset of people who are on statins, but despite using maximally tolerated statins, they are not able to reach their LDL cholesterol goals, and therefore there is a huge residual risk. So we need to reduce that risk. Therefore, the need for this drug. And Sir pointed out to a wonderful molecule which has come in the last 4-5 years, called Pcsk9 inhibitors, and they are also to be used in addition to statins. That they are also not the primary drug, but they are costly drugs, as I pointed out, and no one can use it for a long time out of pocket unless you have the claim, CGHS, Mediclaim, etc., etc. So this is a very, very good arrival in our armamentarium against the fight with lipids, and therefore it has to be taken only in addition to statins. Sir also mentioned that it can be taken along with estimide in those people who are truly intolerant. So what was our arsenal against lipids if you do not tolerate statins? So we had fibrates, we had estimide, and we have Pcsk9 inhibitors, and now we have this molecule. If you combine estimide with this molecule, Bempedoic acid, and you use it over a period of time, then you have LDL cholesterol reduction to the tune of almost 40%, which is huge, and it is a sustained reduction. So the clear outcome data is still not out, as you would have seen from the chart. It was supposed to be out in March of 2022, but not yet out, because they have not met the events, and they have also not met the requirement for the number of patients. So once we get that data, we will be absolutely sure about the utility, but it is already a very promising molecule. There are some questions to my mind. Before I hand over the mic to Dr. Tulsi sir and Dr. Kalra sir, Dr. Tulsi sir, I saw him sharpening his skills. He was cleaning his mobile for some good photographs to be sent to you tomorrow morning. No, he is doing it for you, believe me, not for himself. You will get some good videos, and I have taken permission from Lalit. We can continue this session for next 20 minutes. That is only allowed. I will take only 3-4 minutes. So my question is, you said that this is a good molecule for primary hypercholesterolemia, heterozygous familial hypercholesterolemia. In the last but one slide, there was a contraindication that this drug should not be used in people less than 18 years of age. The problem is familial hypercholesterolemia. If you diagnose at the age of 10 years, then what do you do?
Yes, I think that's a very good question. If you look at the familial hypercholesterolemia, still the reason being that we don't use is the, if you look at the guideline wise and all, we need to have an evidence that it is safe, and that the same is true for even if you look at the, the trials they have excluded. So all the trials, majority of them are done in adult population. So always by default, whenever we are doing some trial or we get to participate in international trials, the first inclusion criteria is that age 18 to more than that 18. So that the reason, so I'm sure that it will be efficacious in them as well, but they have not really been included in trials. So you can discuss with your patient and say the risk-benefit ratio of keeping the cholesterol high versus the protection of decreasing the cholesterol, and off-label use of, can be there. But definitely we have been using statins also in those indications. But if you look at the trials, they have not included less than 18 years in that institution also. So that's the reason why we say that, and basically the coronary artery disease evaluation and all starts after the age of 18. So probably that may be the reason. But those who have got familial hypercholesterolemia, the cardiac manifestations are at an early age, then the family is more aware about that, and they take these statins or Pcsk9 inhibitors. I have got one patient whose family has got a very strong familial hypercholesterolemia, and their son is a footballer, professional footballer, 18 years of age, in Portugal, is now selected yesterday for that. And he wanted to be very fit. So he said, when I signed a document that I want to keep my cholesterol lower, and he's taking Pcsk9 inhibitors, afford it. But coming to the reason why less than 18 years of age we don't recommend, because trials have not included them. So you have to use as per the trial data, and that is why we will come in guideline as well.
So just to come on the same point, they are contraindicated in the reproductive age group 15 to 45 and in pregnant female. Are statins safe in that group?
Yes, in those lines, obviously the statins also we say that you have to use with the research use. So we don't recommend that it should be used in those situations with statin as well.
Sir, we know that statins get, there is a cholesterol synthesis in muscle and in liver. And statins get involved in the cholesterol synthesis process in muscles, and that is responsible for most of their side effects, the SAM, the statin associated muscular symptoms. And sir, you mentioned that it is a drug which should be added to maximally tolerated statins. And we know that at times maximally tolerated statins do have some side effects. But we keep on doing it because to achieve the target. If you add Bempedoic acid to a patient who is taking, let us say, 20 milligram of rosuvastatin, but had issues, mild issues. The OTPT was elevated 3 times in normal, not 10 times in normal. That is an absolute indication to stopping the statin even. Some associated symptoms of myopathy, CRP is not elevated, but he has problem walking in the morning. Once you start this Bempedoic acid, do you immediately reduce the dose of statin to half?
Yes, I think if the indication is to protect them from muscular pain, myopathy and all, then definitely we need to come down. And when the term of maximally tolerated statin dose is, it can be sometimes 10 milligrams, sometimes it can be 5 milligrams also, because beyond that the patient will become more symptomatic, will have rising liver enzyme or the CPK or the muscle pain would not allow him to walk, or some liver issues and all. So in those situations we can add this on, and definitely if the myopathy and all is more, then you add Bempedoic acid, indirectly you are increasing the statin level also, because that the level will go up in blood. So definitely you need to come down with statin dose by half and then add on Bempedoic acid.
Sir, I also want to ask you that it is not only Bempedoic acid which has been approved by FDA, a combination of Bempedoic acid along with ezetimibe has also been approved because of the very impressive results. So, do you see that combination coming to our market?
Yes, I think we have got a lot of apprehension and patients, because being the low body mass index and all those things, we see that patients intolerant to high dose or high intensity statins are even low dose they don't tolerate. And then in those situations, this combination would really, and we have got the data which clearly shows that the combination of ezetimibe and bempedoic would do wonders. Only thing is that we are waiting for the data, whether it translates. So definitely data is there that will decrease the LDL cholesterol or not. But does it translate into significant risk reduction of cardiovascular event and mortality? Probably that answer will also come very soon, as you said. Then I think it will be a wonderful combination.
Sir, my last question. Now, if we add bempedoic acid to statins, we are actually blocking two important enzymes in the cholesterol synthesis pathway. Would it not actually harm the other hormones which have cholesterol as their base? For example, some sex hormones like testosterone. So, your comment on it?
Yes, I think all the major data, nearly more than 15,000 patient data has come, and that has not really translated into that. So initially there was unfounded, apprehension about the risk of problem of getting the cholesterol to too low, less than 40, less than 50. But that's not true. So I would say that it is yet to be proved. So theoretically it may, but I don't think that's a real issue.
Over to Dr. Tulsi.
Thank you, Dr. Chauhan, for those wonderful questions and wonderful moderation, and great talk as usual by Dr. Viveka. So, Dr. Viveka, the ACC 3 days conference at Orlando, April this year, 7,700 attendees. Were you there? Okay, never mind, sir. Why I asked you was because there have been path-changing, practice-changing guidelines today. The trials that have been presented, absolutely amazing trials. Probably, Dr. Chauhan, would you say we'll probably dwell on that on the next month?
Yes, sir.
Dr. Viveka?
Yes, sir.
Okay.
I'm taking appointment for it.
Right.
But not in the place you just mentioned, not in Orlando.
Okay. So, Dr. Tulsi said mic should be closer. Okay, so Dr. Viveka, it's a US FDA approved molecule, and across the Atlantic, the ESC and the European Atherosclerosis Society approved BA, let me say BA for this drug. It's difficult to pronounce. So, for management of dyslipidemia. So let's talk a little about the statin pleiotropic. So, do you see pleiotropic effects here? We know, as you said, that it reduces inflammatory markers like CRP, but does it have immunomodulatory effects as we see with statins? Statins today, we have a pulmonologist friend, Dr. Mangla here. Inflammatory lung diseases, COVID, inflammatory bowel diseases, and what can I say, autoimmune diseases, rheumatoid arthritis, SLE, statins do magical work there. So any immunomodulatory or pleiotropic effects seen here, sir?
Yes, I think that's what we were saying, that will it really fill the gap completely of statins? So the answer is that it's not yet there. So so the pleiotropic effects are not there, except for good effect on HSCRP, and so I think we would have to wait, and that's why the recommendation is that we should be using it in association with statins. So it cannot become statin, but definitely we are talking about the residual risk, the gap in therapy where the patients who are intolerant to what side effect, there we have got something to offer. Before that we did not have. So that's a big step forward.
Right. So a little word about the Samson study. See, the Journal of Clinical Lipidology, 8th June, last month, 2022, said statins intolerance occurs in about 5 to 30% of the patients and contributes to decreased statins intakes and contributes also to higher CV outcomes. I believe these are nocebo effects. as you have multiple, you have said this in multiple times, that these are probably nocebo effects, as these effects were also seen in 90% of patients who were on placebo. So just a word on that.
Yeah, so I think you rightly said that it could be, so it doesn't explain the clear superiority of this molecule, and these effects can be explained by the fact that the patient is taking a molecule and he would feel better with that.
Sir, just a little interjection. 1/3 of patients on statins discontinue their therapy within 1 year. That is a very important figure for all of us to remember.
So, Dr. Chauhan, are these nocebo effects or actual statin intolerance?
It is very difficult to say. As sir mentioned in his talk, there is a patient who came to him and he was googling the side effects, and he told sir, my friends are telling it is a very, very bad drug, don't take this drug. So how much of it is Google and Yahoo and what else we don't know. But the problem is that statins do have side effects, and all the trials in the follow-up have shown that 33% of people drop out of statins. Even in the major trials, the landmark trials, 1/3 people drop out from the trial.
So this is what I said, Dr. Chauhan, about the lipidology. Recently published article, they said 90% of these people would have, even with placebo, the side effects.
Sir, that is to be settled. That is to be settled. We don't know
how many patients have you seen, Dr. Chauhan, who have statin intolerance or actual statin intolerance?
My own brother-in-law has true statin hypersensitivity.
Even I have.
I have been asking sir for some reduced price and some concessional Pcsk9 inhibitors. Sir, despite his mammoth power, has not been able to arrange a single complimentary Pcsk9 inhibitor for me. The company doesn't give.
So how much was the LDL in your patient?
The LDL cholesterol remains about 130 to 140. He is on estimate out of I would say the dose recommended is 10 milligram. I asked sir once, he said 10 milligram सवेरे 10 milligram शाम को दे दो. ठीक है? It will not do any harm to him. ठीक है? When Pcsk9 inhibitors came, I asked sir ये कुछ इसका कुछ जुगाड़ हो सकता है? सर ने कोशिश की, अभी तक जुगाड़ कर रहे हैं, जुगाड़ हुआ नहीं है.
So Dr. Chauhan, so this is a case where probably you could change the statin.
I have already started him on Brilo. The day the Brilo came, I purchased 2 boxes. I gave 1 box to him. He is already
I'm not talking about Brilo. I'm talking about changing the statin.
Sir, I am not saying I have changed statin. He was given 80 milligram of statin the first day when stenting was done in Medanta. He was almost paralyzed, and they thought that he is having a neurological issue. And then they called the neurologist. He said, do you have any issue with that? He said, have you given me any medicine with lipid called Lipitor, which I received in US, and I became paralyzed. He said, you are taking 80 milligram of that. He has never been able to take a single tablet after that. So I am telling you, sir, no, लोगों को याद नहीं होता है, और मुझे भी उसने बाद में बताया कि Lipitor से उसको he almost had he couldn't even drive. So when true statin hypersensitivity kicks in, it is a very big problem. And you can understand for a patient who has just been stented, he needs to be given something. So what was the option? From next day, he was put on EasyDoc or Egentia. Sun Pharma used to give. Now Sun Pharma has withdrawn Egentia. I think they will launch again.
So Brilo probably would be the answer to that patient. Thank you.
I have already put him on Brilo, sir.
Wonderful.
I have the day they launched, I asked Narendra, मेरे को 2 box दे जा. 1 box I gave to my brother-in-law.
And you have changed the statins.
No, sir, he is not taking statins.
No, I am asking you, have you tried to change the statin?
Yes, I put him on Rosuvastatin. Just a minute, I put him on Rosuvastatin, I put him on Pitavastatin. I did everything possible. Now he is on 3 things. He is on Lipaglyn, he is on Estimide, and now he is on Brilo. He is on 3 things now.
Wonderful, thank you.
So, first of all, let me
bow down to all my gurus for Guru Purnima. My juniors and seniors, they have all taught me. Sir,
Sir, you are a humble man.
थोड़ा सा इसको लाइट कर दूं.
You are a humble man.
सर, हिंदू माइथोलॉजी और हिंदू धर्म में बीवी तो एक ही होती है जो स्टैटिन है. जब कोलेस्ट्रॉल लोअर करना है तो स्टैटिन ही आपकी बीवी है. अब सालियां अलग हैं. आपको कौन सी साली पसंद है, इस पे ज्यादा आपका रुझान है. इट कैन बी लेजिटिमाइट.
साली तक ही रहना सब.
It can be Pcsk9 and the new Sali Brillo, which is cute and young and pretty.
सर ललित भी कह रहा है कि सर को बोलो साली तक ही रहना, आगे ना बढ़े.
सर मुझे सर साइड इफेक्ट कोई नहीं होंगे अगर आप ठीक से यूज करो. पहली बात तो सर मैं ये जानना चाहता हूँ कि लोएस्ट लेवल, डॉक्टर विवेका सर, लोएस्ट लेवल, what are the safe levels? 54 is accepted, I think, world over. That if you are
for LDL cholesterol.
LDL.
I think, sir, with due respect to you,
Yes,
sir,
please, sir.
now the dictum is lower the better.
I am, sir. My next sentence was, this has been accepted world over. 24 was accepted in one of the conference presided by Dr. Viveka himself. So has it gone down? लोअर द बेटर वो कहते हैं दिल मांगे मौत, क्या उससे भी ज्यादा मांगते हो? दूसरा, क्या लोकल लेवल पे कोई कोलेस्ट्रॉल सिंथेसिस अलग से होती है जो हम मापते नहीं है? कोई ऐसा भी होता है क्या? क्योंकि अगर हम ये कहते हैं कि उसके बाद पता नहीं क्या सेलुलर लेवल पे प्रॉब्लम हो जाएगी, डिमेंशिया हो जाएगा, because we have lipid layer in our cells. So is it different from the levels which we are measuring? Because there may be different tissue levels and there may be local synthesis at the tissue level which we don't know. We may be probably, we are new to this field.
Yes, I think first of all, lower the better is the new dictum, and we target now that the LDL cholesterol should be less than 50 mg per deciliter or 50% of the baseline LDL. So that is the trick. And as you rightly said, that if you look at the, why we go to the lowest possible level of 24 or 13 somewhere they said, is that the newborn is having, that is the level where it has been considered that this is the safest lower limit which you can.
Which is 45, is it, sir?
40.
The infant type, 40.
So we say that 40, but in some species, if you see the African people where the coronary artery disease has been found to be significantly lesser than, and then the Maori tribes, which is there in New Zealand, there also the coronary artery disease is very low. Where
You will be surprised to know that when cholesterol was reduced, when the outcome data was seen, it was realized that the mortality had increased. And one of the reasons that they found was that people were having more accidents, and they thought that it is something to do with their brain. When you reduce cholesterol, there is an issue with the brain. Am I true, sir?
Yeah, so that was considered, but that was a very small trial.
Very small.
When the larger trial came, that did not show this thing. So what doctor?
Sir, मैं इसको बड़ा लाइटली कहना चाहता हूँ, प्लीज डोंट माइंड इट, कि 1912 के आसपास एक ट्रायल पता नहीं बताया जाता है कि वर्ल्ड ओवर डॉक्टर्स की स्ट्राइक हुई थी और मोर्टेलिटी कम हो गई थी. अब मैं उसको ये तो नहीं कह सकता एक डॉक्टर से मोर्टेलिटी बढ़ती है. एनीवे सर, so doctors are statin and statin are good. Sir, please don't mind, and it may not be recorded in my parliamentarian. सर मैं एक छोटा सा ये कहना चाहता हूँ कि डिसकंटिन्यू करने की जहाँ तक बात है. So I see the maximum numbers of patients who are healthy who come for a health checkup, and I ask them, what are you taking? So when they say we are taking statin and all that, when I ask more details, how many days in a week, then they come down. दो चार दिन तो नहीं भी लेते हैं, और कभी कभी फिर और डिटेल में पूछो तो 1-2 दिन ले लेते हैं. ये तब होता है जब वो अपनी एक्यूट स्टेज से बाहर आ जाते हैं. तो आप वो पूछो तो हनुमान जी को भी वो चढ़ाते ना, जो इतने का प्रसाद चढ़ा देंगे, फिर आधे का चढ़ा देंगे, घर पहुंच गए तो फिर आप क्या 100 रुपये का चढ़ा देंगे, कोई बात नहीं. तो जब वो अपनी स्टेज से बाहर आ जाते हैं तो स्टैटिन को लेना वो कम कर देते हैं अपनी मर्जी से। दूसरी बात, वो डॉक्टर गूगल एंड याहू व्हाटएवर, they also have taught us against statin and steroids. स्टेरॉइड भी जहाँ जरूरी होता है वहाँ पे भी नहीं लेते, वो स्टेरॉइड नहीं लेना। एक वो उनको ये होती है कि आदत नहीं होनी चाहिए, चाहे वो खाली सिगरेट रोज पिएंगे, दारू रोज पिएंगे, पर स्टैटिन की आदत नहीं होनी चाहिए। तो that is one of the personal feeling. So I am saying that the discontinuation is one thing. Are there any markers which can tell us that this is statin-induced problem? Not that nocebo effect as Dr. Tulsi was stressing many times.
So basically we need to look at the liver enzymes and the CPK.
Okay.
So if they are more than for discontinuation 10 times, but more than 3 times the normal value, then it is
I think I will ask other gurus to let's go.
He was saying lowest level of LDL we can go up to 28. I think most of the patients don't achieve 50 or 60, so it's only theoretical. If we achieve 50 or 60, I think you as a cardiologist will be very happy.
Yes.
So 28, 30, more or less theoretical. So is there any chance that this bempedoic acid can be used as a single agent? I think.
Yes, I think we showed the data that those who are not tolerating statin, it can be used as a single agent, and that was the purpose, that those who are intolerant to statin, we can use it standalone. The combination therapy we are now using, achieving even 40-30 when you use Pcsk9 inhibitor, we have seen LDL level going as low as 10.
Thank you.
Sir.
Thank you, sir. It was a real joy hearing you. My question is about the issue of tendon ruptures with bempedoic acid. How real is the issue? Rotator cuff, biceps, Achilles tendon, all important tendons have been mentioned in it. Is it a real practical problem or a very rare issue?
No, so definitely it is a very rare issue, but it is reported, so it could be, so one needs to be mindful of that. So very what we call contact sports or aggressive sports person there we should be avoiding.
If you combine it with the fluoroquinolone, probably tendon ruptures are more. Yeah.
Why should you combine? Sir,
If you are combining, I'm not saying that you should combine.
One
if
small-
you are combining.
One small comment, Dr. Tulsi sir. There has been an issue of elevated uric acid
Hyperuricemia with this drug
with this
has
drug.
been seen.
So what sir mentioned in the adverse profile, and sir mentioned joint pains, and sir said that it is not related to the myopathy. It could actually be related to hyperuricemia. So that one has to keep in mind. And those patients who are already having hyperuricemia, in our practice some people have 7.6, 7, 7.8, and we think no, it's on the upper line. Patient doesn't have any pain. Be careful because it might jump to 9 very quickly, and then he might start having pain. So have a look into his baseline uric acid.
It's one of the safest drugs because drug-to-drug interactions with this
Minimal.
is very minimal.
Minimal.
It doesn't go to the P450 pathway.
Any other questions, sir? Dr. Mathur? No. Sir?
Dr. Chauhan.
Dr. Mathur, sir, एक minute.
Sir, my question is that high doses of statins are supposed to cause prostatic cancer. Many times it has been seen that if you take very high dose of statins, especially atorvastatin, then it may cause prostatic cancer. So to prevent it, why can't we reduce the dose of atorvastatin and mix it with this Brilo in the very beginning?
Yes, I think if you see the causal relationship is not yet there, it's just been insignificant observation. But you are right that if you want to skip or the side effects of high intensity statin, that is what the message was, that when we combine this bempedoic acid with statins, at a lower dose with better tolerability, we will achieve the targets.
Especially with many other side effects.
Yes,
You are
That's
seeing
right.
with statins.
That's right.
One can always give Brilo
Yeah.
with very low dose of statins.
Yeah.
Dr. H.P. Singh, sir.
Dr. Viveka, regarding the placebo effect, you see there are enough examples that even patients taking 5 milligram of rosuvastatin, if you take it for 2-3 days, the legs start aching, and once you stop it, the effect is in 1 or 2 days the pain disappears. So that means there is a direct relationship.
Yes, I think there is no denial that people who are symptomatic, they would have the symptoms. So, in fact, we had one patient which Dr. Chauhan was describing, where after the high dose statin we had loaded, and next day morning he had such an intense muscle weakness that our neurologist made the diagnosis of myasthenia gravis, and he was put on all those things. But when we withdrew the high dose statin completely,
What did you do that after that?
no, so we had to just withdraw the statin because it's
If the stenting was immediate,
yeah.
then
But statin is something which is for long-term good. Acutely, you don't need
if
statin.
somebody is having paralysis like this, then what did you
No,
do
no,
with
statin
that?
was not given to him, sir. Only estimate and dipaglin. Nothing else was given.
Regarding Dr. Mathur's query, there were some studies in which statins showed increased incidence of prostate carcinoma, but after that there are many studies which show less incidence of prostatic carcinoma in statins.
Sir, I think sir cleared the air. There is no causal relationship.
No, less incidence. Now, latest study
Even that is not a evidence-based thing, sir. Dr. H.P. Singh, sir. Sir, you are not angry, na? You are not angry.
I never agree.
Don't angry me. Go ahead, sir. Go ahead, sir.
Sir, my very simple question. In India, 28% people reside in city and 72% reside in the rural areas. So question is, LDL level 24%. What is the level of city percentage in the city and rural area? The question number 1. You are talking about the LDL level 24 or 28. Is it correct? So my question is first, in city and rural area, what is the percentage? Rural area, maybe 70, 80 or 100, or here, maybe 200, 300. So what is your number question?
Sir, question clear.
Number 2, sir.
Question clear नहीं है sir.
सर सुनो हिंदी में बताते हैं हिंदुस्तान में 28% लोग रूरल सिटी में रहते हैं 72% लोग रूरल में रहते हैं रूरल का कोलेस्ट्रॉल लेवल इनका लेवल कितना देखना है किसी में ऐसा है कि जिसमें 24% LDL in city and 24% है किसी में
Let him answer this question first.
नहीं क्वेश्चन नंबर
सर सवाल का जवाब सुनिए ना फिर वो कंफ्यूज हो जाएंगे.
Yes, I think it's a very good pointer that there is a rural-urban divide in coronary artery disease and cholesterol level also. So it has been clear. So we always say that apart from the multiple risk factors like diabetes, hypertension, smoking, all these risk factors, living in a metro city puts you at a significantly higher level of coronary artery disease than being in a rural area or what we call non-urban area. So the cholesterol level may not be low, but the coronary artery disease and cardiac disease are significantly low. So if you look at the incidence in India, there is the rural 4.8. If you look at the Jaipur, there was a study done in rural Jaipur heart study. There it was 4.8% in rural area, whereas in urban it was almost 13.5%. So definitely rural-urban divide is there. So it's not only the cholesterol level, but other risk factors which multiply significantly lesser. So the blood pressure also, so all these things, even the diabetes is significantly lower in rural area compared to the urban areas. So you are right that there is a great rural-urban divide. It's not only in India, but globally it is true. Those people who live near highways, those who live in metro cities, the longevity is significantly lesser compared to those who live in areas.
Sir, अगला
Sir, my question number 2. Those patients cannot tolerate high doses of atorvastatin or rosuvastatin. Whatever today I understand should be subjected to trial.
Yeah, that's
This medicine.
जी सर ये दवाई देनी है सर.
Yes.
180
Now, my opinion, I have read
180 milligram.
if you add with the atorvastatin and rosuvastatin, high doses vitamin D and coenzyme, then patient will not have any complications of joint pain, muscle weakness, lethargy, whatever. What is your opinion?
Yeah, I think that's right. So if you add, so statin as the dose is decreased or change to the Bempedoic acid, or you add the coenzyme Q and all, then also the outcomes.
Sir, if I am right, what is the use of this time?
So just a minute, just a minute, please. Sir, this is a very important question you asked, sir. सर मुस्कुरा तो दो सर। अरे सर
हमेशा मुस्कुराए सर, आप मुझे डिप्रेस कर देते हो, बाकी कोई बात नहीं।
एंग्री यंग मैन ना, बात तो सुनो सर। एक और आपने बड़ा अच्छा सवाल पूछा स्टैटिन एसोसिएटेड मायोपैथी पे, सर ने बड़ा अच्छा जवाब दिया। एक छोटा सा सर मैं सिर्फ इसमें इंटरवीन करूंगा। अगर किसी पेशेंट को स्टैटिन एसोसिएटेड मायोपैथी हो रही है, दो चीजें जरूर रूल आउट करना पेशेंट को। पहली बात यह है कि पेशेंट को अंडरलाइंग हाइपोथायराइडिज्म तो नहीं है, जो आप मिस कर रहे हो। अगर पेशेंट को अंडरलाइंग हाइपोथायराइडिज्म है तो उस पेशेंट को स्टैटिन एसोसिएटेड मस्कुलर इश्यूज के चांसेस ज्यादा होंगे। एम आई राइट सर? नंबर 1। नंबर 2, आपने बात की कोएंजाइम Q10 की, उसको देने से फायदा होगा, लेकिन कोई लार्ज स्केल ऐसा ट्रायल नहीं हुआ है जिसमें इंटरवेंशन विद कोएंजाइम Q10 reduces the chances of myopathy or reverses myopathy. Am I right, sir?
Yes, so numerically the objective the pain is lesser, but if you look at the objective.
तीसरा क्वेश्चन पूछ लूं